Our esteemed panel members that you have before you are Diana Contreras, who's our manager of the Birth Defects Monitoring Program with the Arizona Department of Health Services. We also have Dr. Francisco Garcia, our Pima County Health Officer, Dr. Tim Flood, the Medical Director for the Bureau of Public Health Statistics at ADHS, Dr. Jefferson Jones, who's an Epidemic Intelligence Officer for the Centers for Disease Control, who's co-assigned to ADHS and the Maricopa County Department of Public Health, Dr. Nathan Lepp, who's a neonatologist for NAL, Dee Quinn, a genetic counselor and director of the Arizona Pregnancy Risk Line, and Dr. Irene Roberto, who's a surveillance epidemiologist with ADHS.
Thank you, Jessica, and thank you, everybody, for hanging with us through lunch. So when we last left our roadmap, we were anxiously awaiting the results of the test. And I know Jolie left us in suspense and cliffhanger, so here we are. We've gone through these steps. We have our positive test now. We're going to go through briefly the steps that occur after that at all the different levels. So initially, of course, we have our lab test that occurs either at the state lab or through CDC, and we get that confirmatory result. That goes through ADHS Epidemiology, Infectious Disease, who then shares that information with the county health department. That's where the first level of test interpretation occurs. As has been mentioned a few times, these tests are not black and white. They're not clear, they're not simple, as we would hope with some tests. There's a lot that can go on in the processing and a lot to consider. So the first thing we have to think about is that false positives can occur in patients who have been vaccinated for certain diseases, like yellow fever or Japanese encephalitis, and patients with that were recently infected with other flavivirus infections, such as dengue. So if you have a positive result, it may not be Zika. If you have a negative result, it may be Zika. So, exactly. Hence the first huge hurdle between all of the partners. The biggest thing, we've talked about this a little bit throughout the day, but the biggest thing with the false or the negative result and the question of is it still Zika comes with the timing and the type of testing. So as was discussed several times, and I think we'll discuss it again, really evaluate closely that travel history and the timing of the travel history, the timing of the symptoms, where we are, and look at what to do and how to evaluate how to test, when to test, and what type of testing to use. So if the test comes back positive, we assume that we have a positive case. We have to take this with a conservative method and assume that it's positive. But of course, we're going to take the clinical context and epidemiology information as the next most important factor, if not the most important factor. We really have to look at that travel history. We really have to talk to the patient, have the healthcare provider do what they do best and evaluate the symptoms, evaluate what's going on, and make their best clinical determination with all of the information they have at hand. The next most important thing with a pregnant woman is to make sure we remember that Zika virus infection does not give us any clinical information about the fetus or the health of the fetus or the result of that pregnancy. So two really important things that we have to look at clinically. So I'm going to hand it over to Dr. Garcia to cover both the county health department segment and the provider segment. Luckily, he's qualified for both.
Thank you, Diana. It's a pleasure to be here with you and to chat with you a little bit about how local health officers and local health departments, what our role is in terms of the follow-up of folks who are identified through this process. In general, the role of the local health departments, be they tribal, be they county, will be to notify the healthcare provider of the results. That presupposes that the health departments in those local jurisdictions are part of the loop. And I think that that's a really important assumption that we need to make sure occurs. The local health departments also consult with providers on the test interpretation and counseling. Part of what my job is to do on a fairly regular basis is to communicate with our perinatologist in Pima County and throughout southern Arizona to let them know what's going on with this issue and to talk talk about how potentially to digest, to take in these results. We coordinate vector surveillance and control, as my colleague Diana and her team have already talked about, and we collect additional clinical information from the provider and the patient where it's appropriate. That's where you sort of start thinking about vaccine history, much more specific travel history, and trying to better understand what the level of risk is for that particular individual. And ultimately, in selected cases, we may be the ones that are called upon to assist in linking patients with care and assistance. I'm thinking specifically for those folks who do not have a prenatal care provider, or for those folks who are coming in through the ICE process, through the and through extra legal processes. Oops. There you go. So what's the healthcare provider's role then in all this? The key part is after we've communicated the diagnosis and the tests to our local health providers, they're the ones that are actually going to be informing the patient of the diagnosis, and they're the ones that provide care. And I always remind myself, and I always remind my team, that is their role, not ours. And so that becomes a really important piece of communication. In that capacity, they will do the patient counseling and education. And it's in those circumstances where they will often reach back to us in order to sort of round out the message. The healthcare provider will be doing the one that is responsible for the symptom management. Now, one of the things that we've already talked about is the fact that in most cases, this is an asymptomatic or a minimally symptomatic disease. One of the big pieces, though, that the healthcare provider does on the ground is referring to the appropriate next level of care. Very early on in Pima County, we made a decision that when these queries came in, that we really wanted to make sure that women who were pregnant were being referred to an appropriate level of care, and specifically to a perinatologist, to a maternal fetal medicine high-risk pregnancy specialist. For us, that's critical because there are a lot of things that cause microcephaly, infections just being one group of diagnoses. And it's really important for a woman with a potentially affected pregnancy to understand what the totality of her risk is. In terms of patient counseling and education, it's also critical, even in those cases where a pregnancy is not in question, to talk to women and to talk to partners about preconception counseling so that there can be the appropriate risk mitigation, risk reduction in those individuals. Certainly, if a woman is pregnant and she finds herself in that sort of situation where she's been in a country or she's been otherwise exposed to somebody who's been in a country with endemic spread, talking about mosquito bite prevention, talking about sexual transmission becomes part of the information that we have to sort of impart. As I mentioned before, the actual infection itself is very mild and often has a very subclinical kind of course. And the tests often arrive long after the symptoms have spontaneously resolved. So most of the supportive care that's provided by the physician provider or by the nurse practitioner provider will really be reassurance and supportive care and some symptom management, but we're really not intervening in terms of the course of the disease. So there are things that we know and that we don't know about Zika virus infection and sexual transmission. And what we do know is that Zika viruses may be transmitted during sex by an infected man to his partner. And that transmission may occur when a man is symptomatic, before symptoms develop, and after symptoms end. So it's not clear exactly where along the course that risk completely goes away. One of the things that Rebecca mentioned is that one of the hypotheses is that when people are most viremic, when people have the highest viral load, that they are more likely to be symptomatic. It's still very much a hypothesis, but may explain some of the observations that have been made in terms of sexual transmission cases almost always being associated with symptomatic disease. The other piece is that there is evidence that Zika virus remains in the semen for a longer period of time than it may remain in the blood. However, it's not clear whether the infectivity with the risk of infection actually continues over a long period of time. So I think this is something that we still are struggling to understand. Whether sexual transmission is possible in the absence of symptoms specifically, I think is an important piece. To date, I am not aware of any female to male transmissions. All the sexual transmissions have been male to female, and that one case of male to male. So in terms of the key counseling and prevention messages as they pertain to sexual transmission, I like to talk about making sure that couples in which a woman is pregnant, we reinforce the message that consistent and correct condom use is going to be vital during the duration of pregnancy if you're going to prevent sexual transmission. For couples in which a male partner with confirmed Zika virus infection or clinical illness, in that sort of situation, the use of the consistent and correct use of condoms is recommended over a 6-month period. For folks who are returning from a Zika endemic area, and who are asymptomatic, males who are returning from a Zika endemic area who are asymptomatic, the idea is to avoid intercourse for 8 weeks. And as Rebecca correctly pointed out, these timeframes are based on our best understanding of the information that is available and have a little bit of safety margin built into them. So the actual risk may actually be lower. So in terms of preconception counseling, when we do have the opportunity to talk to women before they conceive, understanding that about half of our pregnancies are not necessarily planned, there's some important messages that I think we need to impart. Specifically for women with Zika virus disease, the idea is to wait at least 8 weeks after the symptoms onset before attempting conception. This pertains, we've seen this play out in our area, or actually in a neighboring jurisdiction, where a business person, a woman business person coming back from an endemic area, the question being, when would it be safe to attempt pregnancy? And so the answer there is 8 weeks if you're asymptomatic. For men who have had the diagnosis of Zika virus disease, again, the idea is to wait 6 months after symptom onset and before attempting conception. And men who have been to an endemic area but who have not been infected to wait 8 weeks. So we've talked about the fact that really our focus on pregnancy and conception is so largely based on the fact that the consequences of infection for the baby, for the fetus, are so devastating. There are things that we know and things that we frankly don't know at this point in terms of how this disease is playing out. In terms of what we know, pregnant women can be infected with Zika virus. That's been established. But most of these infections are going to be primarily through the bite of a mosquito. Yes, sexual transmission is a possibility and has been documented, but it's not clear how much excess risk is being confirmed. Clearly, the main source of the infection is the mosquito bite. And yes, there is clearly some additional risk that's associated with sexual transmission. One of the evidences of that is the fact that in an endemic country like Brazil, you actually see higher prevalence rates in the female population than you do in the male population, and that may be at least partially account for that. In terms of pregnant women, in terms of the risk that once a woman who has been exposed to Zika virus and who has been infected, it's not clear exactly when in the period of pregnancy her greatest risk is. If this behaves like other viral, like other viral infections, her highest risk may be early on in the pregnancy during the first and second trimesters. However, it's clear that this likely represents a spectrum of disease where microcephaly is one end, but that there may be milder forms, milder clinical manifestations that can still occur. And so I think very much the jury is still out. In terms of what we don't know about the full impact of Zika virus on pregnancy and the fetuses, we still don't know what the likelihood of developing disease given an exposure, i.e., if I am a pregnant woman and I travel to Brazil and I go to Rio de Janeiro, what's my actual risk? What risk can I quote that individual? We aren't able to quantify it that finally, nor are we able to predict who is going to have vertical transmission and who is not. That is, whose babies are going to be impacted and who's not. Because at least from what is being seen in Brazil, and again, given sort of the population density, the number of Zika cases is relatively modest in terms of the total number of Zika infections among women and even among pregnant women. The risk of and range of birth defects, like I mentioned, is likely going to be a lot broader. Already there are some reports of specific eye anomalies and other brain findings sonographically and in aborted fetuses. And so we know that there's probably going to be a range of disease. And there may actually even be some long-term kind of developmental consequences for those infants that survive from this disease. In terms of the differential impact of timing and gestational age, I already mentioned, we still don't know. Is there ever a safe period of time in which a pregnant woman can be exposed to Zika? We're just not able to ever identify that. Although clearly you would think that the risk would be slightly lower later on in the third trimester of pregnancy, theoretically. The fact that transmission is actually possible at any point is something that has to sort of make us very cautious. And one of the key messages that we've been conveying in Pima County is to avoid travel if you are pregnant or if you are planning conception and you're a female, because it is just that concerning. So the algorithm, this is the algorithm in terms of the next steps for the woman after she has her Zika testing and after we get those results back. And before I sort of talk about the algorithm, let me just point out the fact that this algorithm is the whole reason why taking a good travel history is really important. Because regardless of where you end up on the algorithm, either if a positive or a negative test, the consequences, the follow-up is pretty intense, right? So if you're a pregnant woman who has traveled to Canada and had some mosquito bites, and you are concerned about Zika because you're hearing about this, or your physician's concerned about Zika because he's hearing about, or she's hearing about mosquito bites, we want to avoid you going down this route, because either way, that patient is going to need to be followed up fairly intensely. So for a woman who has a positive or inconclusive Zika test, the next step is obviously to notify the local public health department, and at that point, in coordination with a care provider, assess whether that fetus has any sonographic evidence of microcephaly. If that is indeed the case, then there's the option of being able to test specimens like amniotic fluid and fetal tissue for PCR, sending off for PCR for further testing. If her tests are negative, however, she went to a endemic area, she still needs to be monitored very carefully. In this case, the recommendation is to perform a routine fetal ultrasound at 18 to 20 weeks to assess for fetal anatomy. In that case where you see microcephaly, you go down the microcephaly route. But even if you don't see microcephaly, again, because it's not always so crystal clear, and because again, it's likely a range of disease presentations and not just microcephaly that we should be worried about, that fetus, that pregnancy is going to need to be followed fairly closely. And we're going to need to, and that's part of the reason why we're going to be talking about the pregnancy registry and why it's so important. So what are the next steps for pregnant women after a positive Zika or inconclusive test? At that point, we engage the local public health department. Again, we consider referral to a perinatal risk assessment with a high-risk pregnancy care provider, serial ultrasound, amniocentesis. When do we think about amniocentesis? Well, when you're going to be thinking about performing an amniocentesis for other infectious causes or for other non-infectious causes, remember that this is not the only etiology for microcephaly, that there are other flavivirus infections and other viral infections that are associated with microcephaly. So if a amniocentesis is being considered in that evaluation, or because you're looking for a chromosomal anomaly, then it may be logical to add a Zika PCR to that test. Finally, there's a connection between Zika virus and adverse pregnancy outcomes. However, the actual risk for microcephaly and other birth defects continues to not be well defined. So this is very much kind of a moving target, and we need to all sort of be aware of the fact that it is. And we need to be able to convey that with all its complexity to our patients, and I think Dee will be talking about that. In terms of pregnant women living near the U.S.-Mexico border, we were, I think, one of the first health departments to say, no, you can't just make a blanket prohibition for pregnant women to travel to Mexico. It's just not that easy. Currently, there are absolutely no reports of local transmission along the U.S.-Mexico border, except for the state of Nuevo León, which fairly early on had approximately 4 or 5 cases, I can't remember, and has not had any subsequent cases. Now, I happen to know folks in Nuevo León, in Monterrey, and there was actually some conjecture about whether these were really endemic cases versus travel-acquired cases. For those of you who don't know Mexico, Monterrey is a big industrial hub. There's a lot of Brazil Monterrey travel. And the question was, were these really endemic cases or were these imported cases? In terms of what healthcare providers for pregnant women who live along the U.S.-Mexico border, we really need to do a good job of assessing our patients' travel history and try to figure out where in Mexico they visited. I'll disagree a little bit with Rebecca in that in some of the areas that we're talking about active transmission are actually some areas that have some significant tourism. For women who travel across the border regularly, daily or weekly, to areas of endemic transmission, healthcare providers should follow the CDC's guidelines for pregnant women residing in areas with ongoing transmission. So here's the map that we've all been referring to, and the darker the brown, the greatest number of cases. But suffice it to say that the bulk of the cases continues to be in the area of Chiapas, Guerrero, and Oaxaca. For those of you who don't know Mexico, these 3 states. There have also been recently cases in Jalisco and Michoacan and in Veracruz. Why is this important? So if you go to Puerto Vallarta, you're going to be in Jalisco. If you're going to go to Acapulco, you're going to be in Guerrero. So it's important to understand exactly where your returning travelers are coming from. For those of us who take care of patients who may be immigrating to maybe part of the illegal immigration route into the United States, understand that migration route actually takes you through those 3 endemic states for the most part. And so even when individuals may not have been exposed in their home country, we really need to sort of keep in the back of our heads that is a possibility. Now, I say that with some trepidation, and I say that with some angst, because these are folks who are already pretty stigmatized. But I think it becomes really important in terms of the quality of the federal, state, and local collaboration for us to sort of have a good situational awareness of the folks who are passing through our communities. So I'm going to turn it back to Diana.
Thank you so much, Dr. Garcia, for covering both of those sides. So once we have that positive and the provider and the local health department work together to communicate that and interpret the disease, back at ADHS, we're still working on that. It never closes for us. We have several roles in this process, including some that have been mentioned before. A lot of it comes around surveillance, but it's also reaching out to our partners immediately if there's refugee resettlement involvement, if there's other state involvement, if there's international involvement. Looking at the registry, which we're going to go into some detail. So we have a lot of partners involved at this point that aren't mentioned, but are constantly engaged throughout the process. So our ADHS surveillance has been briefly covered a few times today. At all times, we have a variety of registries covering a variety of disciplines. We have cancer registry, we have birth defects, we have the infectious diseases, which includes the arboviral diseases, which are constantly being transmitted up to ArboNet to CDC. This goes on all the time because we want to know what's going on in our state at all times, not just when there's a Zika panic. Way prior to that, we were looking at these diseases. Way back in January, we were having these conversations. Our birth defects program, Tim was picking up, hey, there's information coming out that's connected to microcephaly. Let's start talking about this internally. Our infectious disease partners were talking about it. We very quickly knew we needed to come together to talk about it, to have this unified conversation and decision-making process. Public health does surveillance for a reason. It's not just to count, it's not just to look at it. And Zika is a great example of why we do these things. We want to know what's going on in our state. We want to be ahead of the game. We want to be able to share that information, accurate information, not looking at the whole state of Mexico or the whole country of Mexico, but at these pieces that are really important to Arizona and our community. We look at trends, we look at clusters, we look at guidelines from that, or we develop guidelines, and then we continue to evaluate that to see if it meets what's currently going on in our state. We adapt our algorithms from CDC to in a way that makes sense for our state based on our surveillance. So then along comes Zika or something like that, and we have a heightened alert, we have more partners engaged, and specifically related to Zika, we did develop this pregnancy registry, or CDC did, and they engaged their partners. And then CDC and the National Birth Defects Prevention Network also started looking at that other side of microcephaly and started developing some registries and processes to look at that more in depth. So in detail on the pregnancy registry, as promised, I know you guys have been waiting for the details. So the purpose of the U.S. Pregnancy Registry was really to monitor what's going on. We saw this concern with Brazil. We knew there was something we needed to look at. CDC took this upon itself to really get the information not only about the pregnant woman and the fetus at birth, but long-term outcomes. We want to be able to inform our partners, and CDC uses its states to get a much broader look at what's going on nationally, internationally, and to really be able to inform the response and the processes. Be able to look at recommendations for clinical care. What's going on now? What do we need to adjust as we go? Planning for services for both the pregnant women and the infants. And working on prevention, improving that as we see. Like we said, we don't know when the greatest risk of transmission is. We don't know late trimester, early trimester. There's so many things we don't know because this is really still pretty new. So by using this pregnancy registry, by getting this broad information, we hope to be able to inform some of these processes. So who's included in the registry? Everyone. The pregnant women, any pregnant woman with laboratory evidence of virus infection, and their infants. And also an infant, even if the mom was inconclusive or negative, if an infant is born with congenital Zika syndrome, or there's evidence of that, we will include the infant and then go back and include the mom. So both parties are being entered, often at the same point, but sometimes there's a little bit of a delay between bringing the next one in, depending on what that process is. So different than other arboviral reporting, we include asymptomatic and symptomatic. Some of the ArboNet processes, correct me if I'm wrong, only include symptomatic cases. If they're test positive and they have symptoms. For the pregnancy registry, we don't care because we don't know what the difference in that is yet, and we need to find that out. So if we have laboratory evidence of a pregnant woman having Zika, we will include that mom in the pregnancy registry. And I think that's going to be critical to inform our future processes and decisions. The data that's collected is pretty extensive, to be honest. It's a lot of what's already collected about the arboviral disease, what's already being submitted to CDC, and then a lot more information, the travel information, the demographics, the symptoms, when they occurred, when they traveled in their pregnancy, when they conceived, a lot of pregnancy information, a lot of infant information. A lot of it's already being collected through routine care, prenatal care, early doctor's visits for the infants. It's not a lot more than what's already being done. It's just a little bit more involved, relating it to that pregnancy and to that potential infection, and then reporting it so we can get this pool of information. So recently, CDC has transitioned to weekly aggregate reporting. The reporting for numbers varies across CDC. So the general CDC is reporting those symptomatic women, or those symptomatic positive women. Pregnancy Registry is reporting asymptomatic pregnant positive women. So the numbers are a little different. Right now we're at, or as of last week, we were at 157 pregnant women residing in the US. This is just at a glance. You can actually go to the CDC website and get this view real time. It's updated weekly, as I said, so anytime you want to know, it's right there. CDC has also done a fantastic job of putting out information about the pregnancy registry. So states are not required to come up with this themselves. They have a handout for providers and they have a handout for patients. They're also allowing the states to tailor it a little bit to make sure it works for what your state is experiencing. So there's some great information out there. We do have access to it. It's available on CDC website. So if it's something that could be beneficial for your patient or your clientele, go to CDC. There's a lot of great handouts up there. So what does it mean for the infant? We have this whole registry we're talking about. What about the infant? We've covered kind of the other side in detail. We're going to get a little bit more nitty-gritty with the baby now. So it was touched on a little bit. An infant that is born without microcephaly or without known defects, what are we doing? If the mom traveled and the baby was born fine, again, it comes down to travel history. Dr. Garcia, we've talked about that a few times. If the baby's born with symptoms and there's a travel history in the mom, we want to test that baby. If the mom hasn't been tested, of course we want to test her. If she was tested previously and it was negative or inconclusive, because we remember that negative doesn't mean negative, we want to test her again. And then we're going to process the baby. We're going to take care of the baby as we normally would. But this is another way we might be catching Zika that we might have missed early on. If we had an asymptomatic mom, sexual transmission, if we didn't catch that, if it was an area that we didn't know there was ongoing transmission, she wasn't too worried and she decided, oh, I'm not having symptoms, I don't need to be tested. We have a baby that's born and has some of these symptoms. It has the rash or conjunctivitis. We're not going to know a lot of our infants have joint pain, so there's the tough one. But we have to look at our babies, and that comes down to our early providers, our pediatricians and our neonatologists, to be aware that Zika is a possibility. Again, assess the travel history and consider testing. Most of these algorithms are in your packets too, so feel free. We're not going into them in too much detail, but you do have access to them both online and again in your packets. So again, if the baby is born without microcephaly, without any significant abnormalities, consider travel, consider symptoms, consider testing. I'm not going to go into the details of it. There's a laboratory section, but there is a little bit of information on there about what can be tested. And it is expanding every day. For an infant born with microcephaly or with evidence of another CNS or birth defect that's concerning, again, review travel history. Take home message, right? We keep saying that. This really comes down to that because there can be a lot of extensive testing or a lot of misdiagnosis if we're not doing that. Consider other causes of these abnormalities. As Dr. Garcia mentioned very clearly, microcephaly is caused by a number of things. A lot of different infections, fetal alcohol exposure, a lot of diseases, genetic causes, chromosomal causes. We've seen microcephaly forever. We just haven't seen it before with something like this. So consider all of the other causes. Assuming it's a significant enough case, we're going to look at it a little bit closer. Your neonatologist is going to be invited in. They're going to run their standard tests. They're going to run their standard infectious disease screenings, assess the mom for any alcohol or drug use or exposure. We're going to do all of that. We're going to look at whether or not this is considered disproportionate. If it's just a small baby born to a small mom, probably not a big deal. If it's disproportionate, if it's a really, really small head to a regular sized baby, usually we're going to see the head being spared if there's an abnormality of the baby. The blood flow, everything's going to go to the head, it's going to develop normally, and the rest of the body is going to be small. So if you're seeing the opposite of that, that's a concern. That's where we want to consider what's going on. And that's where we kind of use this blanket term of clinically significant. Does it look like this is going to have a long-term effect on the baby? Does this baby look normal in general, and they're just small, but they're fine, all of their APGARs are fine, everything's looking good? Do we need to do more? That's not my question, but we have our experts, and that's who we need to consult. Again, it's always going to come back to your provider to make sure we're assessing the baby as we normally would. We just want to make sure we're also considering Zika as a possibility. And at that point, we're really just looking at patient management and referrals and reporting to the Birth Defects Registry. That's the new piece. Very detailed algorithm. Not going to go through the whole thing. But again, it's really taking that provider through the process of thinking Zika. We've never had that before. We have our standard things that we always think. We always think CMV. We always consider fetal alcohol. We've never had to put Zika in the picture. So really trying to get the physician to consider, we don't know what's causing this. There's no genetic history in the baby. There's nothing else. We've done our chromosomal testing. Yeah, maybe it could be Zika. We want that last thought to go up and do we need to run a test? We have a fantastic lab. We have the capability to test it. We need to consider it when possible. So coming back to the birth defects program, we've existed for a long time. We already conduct statewide birth defect surveillance. We conduct surveillance on about 37 different categories, which is over 150 birth defects, including a lot of the CNS defects, the eye and ear abnormalities. Some of the other things we're seeing now are some musculoskeletal type things. We collect those, we look at those, we look at trends, we have time trends, we have different views. We've recently resumed microcephaly reporting in response to Zika. Most of the states across the country had dropped microcephaly surveillance because there's a lot of issues with diagnosis. We'll get into that a little bit. But we have recently resumed, and we are doing retroactive reporting or surveillance of microcephaly going back to 2014. So again, you've seen this slide. I love that we're all consistent on our pictures. So it's determined clinically. The measurement of the head is less than the third percentile, and it's looking at if it's disproportionate, clinically significant. And this is why we have an issue with reporting, because what one physician may determine to be clinically significant, another one may not. Some may go just on that. Yep, it's less than third percentile. It's microcephaly. But it's a normal baby, it's a twin, it's a triplet. Of course it's gonna be smaller. So it's a tough one to get great information on, but that's where, one, the birth defects program comes in, and two, that's why CDC and MBDPN are working on that to have a cleaner definition to really evaluate what's going on and make sure we're collecting this similarly across states. So in the absence of current data, in the absence of the current real-time collection that we have, our fabulous epidemiologist was able to put together kind of a time trend of microcephaly using our hospital discharge data. I will say that none of these cases were confirmed, but as Kara mentioned, we needed a baseline. We need to know what we've been looking at over time. And we know based on confirmed cases versus hospital discharge data, we do see some consistencies. So we can get some pretty real numbers, a pretty good look at what's been going on at our state over the last few years, and we will be able to see if there's an uptick. Why is this important? We may be able to identify other Zika cases. We may be able to identify Zika in a different way. A mom that looks normal, a mom that didn't travel. Again, 20% are symptomatic, 80% are not. So there's this perinatal process, there's perinatal time period where I wasn't pregnant, but I had sex with somebody and they traveled and I'm not sure and they didn't tell me they traveled and I didn't know I was pregnant. There's a lot of ifs. There's a lot of things we don't know. A lot of people that aren't trying to be pregnant at the time, so they may not be tracking it perfectly by date. So we're hoping that by looking on the other end as well, you have this baby born with microcephaly, we test them, we may find some cases. We're also going to be able to compare our cases to previous years, going retrospectively. We'll see if we have a rise in microcephaly. And if there's no other found cause, if we don't know why these cases are there, we put them in the unknown category. If this unknown category grows exponentially, we have to consider that maybe Zika was broader than we thought. Maybe a lot of these asymptomatic cases that weren't being tested, maybe we need to change. Maybe Zika testing becomes part of standard prenatal care. I'm just throwing things out there, I don't know. But because there's so many things we don't know, this is one last chance to kind of catch those cases that we may have not caught sooner. The other thing, going back to what Dr. Garcia mentioned, we don't know what these babies are going to look like. We don't know the full level of it. We're working with the pregnancy registry. The only way the pregnancy registry gets that information is through us. We're working with the National Birth Defects Prevention Network, and again, the only way they get that information is through us. So they've developed a very detailed report for cases that could potentially be related to Zika. And so we're looking at that full spectrum of the etiology of what's going on with these babies. So far, a lot of the babies we've seen out of Brazil it's very, very severe cases of microcephaly. There's a lot of, we see the eye abnormalities, we're seeing some ear abnormalities, we're seeing clubfoot, we're seeing a lot of different things, but we don't know yet. So by doing this enhanced surveillance, we are going to hopefully get a better idea of what this looks like and be able to plan and be able to say 1 in 4, 1 in 20, because we have no idea who and how many right now. So back to what providers need to know and what do we need to do, it comes back to just your general follow-up. If it's an acute Zika infection in a baby, as we've said earlier, symptoms are generally very mild. In fact, what we're seeing so far is that Zika in an infant is more mild than other flaviviruses in infants. So where the symptoms may be exaggerated for like dengue or West Nile in an infant, for Zika, the symptoms tend to be more mild in infants. So that's good news. But again, the full spectrum, we don't know. So far, we assume, and we're not seeing any long-term detrimental effects for a baby that has acute Zika infection. To date, in the literature, there's only been 2 cases. One had a rash, one didn't. So for an infant with a Zika-infected mother, we know there's a variety of possible outcomes. We've covered it a few times, but basically, normal pregnancy, no problem, pregnancy loss, or what we're now calling congenital Zika or congenital Zika syndrome. And again, the moms and babies are followed through this registry so we can get a better idea of what's going on. On a side note, and I think it was mentioned earlier by Rebecca, at this point we haven't seen any issues. Zika is present in breast milk, but it hasn't been transmitted from mother to baby. I'm getting nods, yes. So, and also same with saliva, so there aren't any immediate concerns with that. Congenital Zika syndrome. So it used to be congenital Zika virus. Now the word syndrome is being used a lot more because we do know there's a lot more going on with these babies than we had originally assumed or we had originally seen. So the definition right now, although there's a proposed change that just came out yesterday, right now it's an infant with these defects or with these concerns, so microcephaly, intracranial calcifications, CNS abnormalities, whose mother either lived in an area, traveled to an area, or has clinical evidence of Zika. The possible list of defects that we're seeing, again, microcephaly, CNS and brain abnormalities, which can include intracranial calcifications, eye abnormalities. Now we're hearing of ear abnormalities, musculoskeletal defects, which I mentioned, club foot, joint contractures. The list gets longer every time a new post comes out from whichever agency puts it out. So we're not there yet. And again, that's the importance of the registry, and that's the importance of the surveillance. Our key piece, coming back to the state and coming back to the providers, is really making sure we're doing that follow-up and linking to care. The pregnancy registry relies on those pediatricians doing those evaluations at key points. Our surveillance is going to rely a little bit on that. The child's well-being is going to rely on that as the bottom line. So we're doing that follow-up. We're linking them to special needs as possible. Microcephaly is a CRS, Children's Rehabilitative Service condition. We have our Office for Children with Special Healthcare Needs that can help link. The Birth Defects looks with that. We work with our data with other groups to make sure those kids are in care. And the providers need to do what they would always do. Zika doesn't change the outcome for that baby. It's their diagnosis. They have microcephaly. We generally have 50 to 100 cases of microcephaly a year anyway. We already have those systems in place to make sure those kids have care. It's just a matter of following that. So as you've heard, it is a statewide partnership. between plenary 1 and plenary 2, we've covered all of the roles of all of the different pieces, the providers and the state and local public health. We have a lot of public-private partners here that are involved in this, and luckily a lot of you are here today. March of Dimes, Perinatal Trust, APA, or AAP, so many groups that are involved in this, so many conversations going on, and then it doesn't stop at that level. We've talked about CDC. NIH is involved in this deeply, looking at research. WHO is involved? So many agencies, and it's a constant collaboration between all partners. And I think that's critical for this because, again, so much we don't know, but we know it's affecting different continents. It's not just Arizona to Mexico. It's all over. And the bottom line, when you look at all of the partners, when you look at all of the pieces, we took our roadmap up and down. We've seen it through piece by piece. It all comes back to the patient. The bottom line is that whether you're considering Zika, at what point you're considering Zika, at what point you're seeing microcephaly, it really comes back to the healthcare provider taking care of the patient, which becomes mom and baby if it's a pregnancy, and then the state and the county providing support to that healthcare provider and or the patient as needed. So it's really a group effort, and I'm gonna say, first of all, Arizona's done a fantastic job because we came together very early, but the number of people here today learning about this and having conversations, that's the bigger part of that partnership. So I'm gonna say thank you for that because as one of the ones conducting surveillance and having these conversations, this kind of engagement is critical. So that's all I'm gonna say now. We do have, we are gonna open it up for questions. We have a great panel of experts, all of whom have been very involved in this process. Any questions from this morning or from this session, feel free to ask because I'm willing to bet most of our panelists can help with some of those. We did have one question that's been asked a few times today. It's been talked about, but it was very specifically asked in a lot of the questions pre-submitted. So I'm gonna open with this one, and I'm gonna address it to Dee Quinn. How safe is it for pregnant women to apply insect repellent? Should we wait to tell people to do that until locally acquired cases arrive, which I think we've covered that. But also, what about those babies that are less than 2 months or less than 3 years? Huge insect repellent message. What about the babies? And really speak again to the safety of that, both for the infants and the pregnant women.
So this is really, it's a difficult issue because we certainly want pregnant women to be careful, and we've sort of gotten that message across, and so now they're sometimes, can you hear me okay? There we go. A little overly concerned about exposures. But all of the data that's been collected so far, and I have to say that it's not as good as we would like it to be. So there has not been a huge prospective study looking at pregnant women who have used DEET. But someone this morning said it absolutely correctly, and that is this is a risk-benefit balance, and you sure don't want to get Zika. You know, and I think that's the message that we have to give. Now, DEET comes in different strengths. And a colleague of mine recently said, well, use the lower strength. The problem is that the lower strength, it's not that it's lesser strength, it lasts shorter time. So it only lasts 2 hours. I think it's like a 30% versus 50% DEET. I don't know about you, but I don't think I'd want to put pesticide on every 2 hours. So in some ways, it makes sense to perhaps think about using the longer acting ones in terms of compliance. But all of the data we have so far just doesn't suggest that there's any problem with using insecticides. But I hear from pregnant women all the time. So I'm going to shamelessly publicize my service. I'm the director of Mother to Baby. It's a toll-free phone service where pregnant and breastfeeding women can call about exposures. I have some brochures out on the table. And so I talk to pregnant women all the time. And, you know, I do appreciate their wanting to be careful, but I think this has to be presented as a risk-benefit balance. If there is a potential for getting Zika, then they really need to use insecticides as much as needed. And it's unnerving, I think, that they're in the home. So it's not that, oh, just when you go out in the evening, it's all day. But that is currently the recommendation. Now, Diana asked me about a less than 2-month-old, because you're not supposed to use insecticide, and I sort of went blank, and I'm glad she asked before she asked now, because then I came up with one possible solution, and that is that in a lot of countries outside of the United States, they use mosquito nets. And that would be a really good tool for a baby less than 2 months. They're not going anywhere. And so a mosquito net might be the absolute best thing for those infants that are less than the age at which we want to use pesticides or insecticides. I'm so impressed with the forward thinking here. I've been involved in other outbreaks that have affected pregnant women, and they didn't go so well. I am just so impressed with the amount of information that's available. I would strongly recommend you look at the CDC website. There is just fabulous information. But the organization I work with, which is mothertobaby.org, we also have fact sheets on our website that are written at a 7th grade level, written in Spanish and English. They're free. So you can certainly refer patients just to that website. There's one on Zika, and there's also one on insecticides. So to help answer that question, or to help them perhaps feel more comfortable using insecticides, you can certainly refer to that.
Thank you, Dee. Another question that was submitted was, if a pregnant woman, asymptomatic, non-infected, has sex with a Zika-infected man, so while she's pregnant, what is the risk to the fetus? So if she's doesn't have this active virus, as far as we know, she has sex with him, is there any result, does that get transmitted from the man to the baby if it doesn't get transmitted to the mom? And is there any relation to gestation? Do we have any, Jefferson? Nathan, whoever wants to jump in.
I'd like to double check. So this is a asymptomatic man and woman. The man has traveled.
Zika-infected man.
Zika-infected man.
Asymptomatic, as far as we know, the mom
Okay.
does not have the virus.
It
So
was-
basically, does that get transmitted from the man directly to the baby?
So the quick answer is we don't know, but what we do know is that all reported cases of sexual transmission have occurred with symptomatic males to their partners. Because of the lack of knowledge, the recommendations that come out that any man, symptomatic or not, when they return from travel, should either wear condoms or avoid sex with pregnant partners, and that's because we don't know. So is it possible that symptomatic or asymptomatic man who returns can pass that to a pregnant woman and it gets passed to the fetus? I think right now the assumption is that is enough of a possibility that the current guidelines have been issued.
And one last question that I want
Sorry, before,
No,
just
please.
real quick about the less than 2 months. As far as getting compliance, certainly for people traveling to countries where there's active ongoing Zika transmission and you're bringing an infant less than 2 months, perhaps mosquito nets are a valid, and possibly compliance wouldn't be as much of an issue there if it was necessary to travel. In Arizona, certainly long clothing, rather than people just taking walks in a stroller with their baby, rather than just doing a onesie, encouraging long clothing, both protecting from the sun and mosquitoes. And then there are various stroller covers that are available that could potentially prevent mosquitoes as well.
So because I know one of the other protective measures is to treat clothing, are the ingredients in those materials the same as what's in the repellent and as the same risk there for the infant? Would we ever want to treat bedding? Would an adult ever treat their bedding where you're not treating your clothes with that constant inhalation? Like, would we ever use those mosquito sprays that last for 6 washes on bedding?
It's a totally different chemical. It's pyrethrin versus DEET. And all three of us are like, we've never seen any recommendation one way or the other on it. And I see a lot of shaking heads out there as well.
But we do recommend permethrin for other head lice in pregnant women.
Right.
So-
but I mean,
so-
in terms of like on baby clothing or
On
something.
baby clothing,
I
that's-
don't,
yeah,
I don't
how
think
would
you're ever
you
going to see any
treat head lice?
recommendation on that.
How would you treat head lice in a 6-week-old?
You don't see it that often. They don't have that much hair. They're not going to school to get it, so that's a school age thing. But I don't know that I've ever seen any recommendation on treating baby clothing with any of those that you would like for adults or even kids.
Just to
I honestly
clarify
don't
what
know.
we're talking about, are there packets you can buy at a sporting store? and you throw them in the washer with your clothes. And they have insecticide and it lasts, I don't know, some amount of washes, which is another really good recommendation or thought. But
As a recommendation.
And there's also spray cans, aerosol cans you can buy of it that you can
Spray on your clothes.
spray in your clothes, your socks for certain areas and stuff. I see a question out there.
Since you guys obviously know a lot more about insect repellent than I do, I was wondering if you could help supply the data behind why you can't give. I think the oil of eucalyptus or lemon oil of eucalyptus is a really attractive insect repellent for moms, especially moms in this country who want to do things that are natural. And the recommendation is not to put those on infant or children less than 3 years old. And I was wondering, is it just because they haven't been tested on that age group, or is there actually adverse data or adverse outcomes from it?
I don't know of any adverse outcome data. I think there's a few things when you're dealing with, especially with infants, the absorption, and you just don't know what the absorption is going to do. I don't really call it pharmacokinetics because they're natural oils, but I think it's just because we don't know, and the baby's brains are still very actively developing. So I think it's more of a unknown as opposed to a known risk. And that's even with a lot of things, like even with breastfeeding, there are certain categories in breastfeeding. You know, there's a lot that we just don't know, and so we tend to err on the side of probably just shouldn't do it. As far as, I can't speak to, even less than 2 or 3, but some of it also may be irritants as well. Some of those oils can be irritants, and how much it's absorbed into a child's skin or an infant's skin may be variable compared to that with even an adult.
Thank you.
Beth?
I know eucalyptus oil, when it's ingested, can cause metabolic acidosis and mental status changes. So
Right.
it may be in that toddler age when it's on their skin and they're putting their hands in their mouth. It's an ingestion
Could be,
risk.
'cause they're always sticking stuff in their mouth.
Question in the back? Dr.
I'm going to change the topic from pesticides to antibodies. I'm Dean Coonrod from Maricopa Integrated Health System. Why is it that IgG is not used, the long-term antibody? Is it just too cross-reactive with other flaviviruses?
Okay, the quick answer is that there's no commercially available test. Kind of longer explanation, yes, it is known to be more cross-reactive even than the IgM antibodies. The PRNT test for the neutralizing antibodies utilizes both a particular subset of IgM and IgG antibodies, but as was alluded to this morning, while they have more specificity, we're still having trouble with those as well, cross-reacting.
Because it would seem, if you had some long-term thing, you could learn a lot more about, its effects in pregnancy, et cetera.
Yeah, for now, the PRNT antibodies do seem to last for years, but as far as currently, we haven't. There's no good protocol for data to be able to specify when is a good cutoff date to have reliable, interpretable test information.
Thank you.
I mean, a need for a new test or a better test is fairly apparent.
Sean Elliott again. This question comes from my background as a pediatric infectious disease specialist. It's not uncommon to be called to consult on a patient with mild microcephaly only to measure the head circumference myself and find that, in fact, it's normal. Mm-hmm. Is there, or could there be, plans to share a standard approach to measuring the head circumference, which could be part of our outreach and our publication record?
There is, and the nurses are supposed to know how to do that. Honestly, I mean,
Yes,
I don't mean
true.
that to be glib, but it's true,
Yes.
and I will tell you that is my experience too as a physician who, the interoperative variability in measuring head circumferences is ridiculous.
Correct.
And that is why that makes this discussion about using third percentile for microcephaly very difficult. I would throw it out to also the practitioners, and if they do get a baby where the nurses are on the growth chart, it's one way, then it is up to them to also, measure it themselves. I had one the other day, a disproportionately small baby's head was about 10th percentile, the rest of the baby is 50th percentile, and I remeasured just to make sure that it was, and it was, and fortunately mom didn't have any travel history, so we have other issues going on, but that is just, there is this standard nursing way that they're supposed to be doing it, but part of it issue is too, for those of you who seen, freshly hatched babies. The heads, I mean, you're cone-headed when you're born if you're born vaginally. So as things kind of shift like they're supposed to, the OFC can change. Also, you can have caput, you can have cephalohematoma. So there's a lot of things in there that can affect those measurements as well, and that's why it's such a frustrating measurement compared to like weight, which is very, exact. So it makes it a little squishier, which is unfortunate when you were trying to be very exact with the third percentile issue. So I think if a hospital, if we were to see, we do this even with newborn screening, for example, if we were to see, or even CCHD screening, things that we currently do where we do quality initiatives where Sandy is working very closely with the hospitals. If we were to see a hospital that has a unusually high rate of reporting microcephaly, then there's two things going on there. Either that has a very unique patient population, or there's maybe some operative error there in that, and there's an education opportunity like we would do when we have problems with our blood spot screenings or our CCHD screenings or hearing screenings for that matter.
So there may well be an opportunity to partner with the Arizona AAP chapter that I'm on the board of directors for, just to get that education out. Yes, we all should do it, perhaps to remind our practitioners to confirm that head circumference testing.
And also to pay attention to it, because I know it's all these things are done on admission by nursing, and I don't know. I'd like to believe everyone always looks at that growth chart, but you and I both know that that may not always happen if a baby just looks okay. So.
Right.
Thank you.
Dan, if I could sort of reinforce something that Nathan said, which is really critical, and that is that especially immediately postpartum, kids' heads can they can look alien, quite frankly, and that's just how it is. And so that first assessment is often, especially in a patient who has labored a long time, maybe put some forceps on. Geez, I mean, these kids' heads look horrible. The other piece is that remember that one of the key things is when the head is lagging the rest of the measurements. That disproportionality becomes really, really important because we are a range of people. My boys, by the way, were 5th and 10th percentile intrauterine percentile at the 2nd and 3rd trimester, and they're completely normal. We're just smaller people. That's okay. So it's that disproportionality when you get big lags between the rest of the biometrics and the head circumference that you start becoming very concerned.
And I will say, too, at the beginning of this process, CDC and NBDPN were working to kind of come up with that guideline. That's one of the biggest reasons that as a program we quit collecting it in most states because there's so many issues with it. And because of that, I think the national level, they're really looking to better define that, to better educate. They have put out some new tools that go much to an earlier period, so the preemies are getting measured differently and properly. So there is a lot of education, but absolutely we're going to rely on some of our key partners to make sure that information is getting out there.
It may also be prudent to start the message, maybe not the very first head circumference, but the one prior to discharge or on the first postpartum check, running the risk of losing some of those babies. You got to capture them when they're there, but perhaps waiting until a little bit later in the discharge rate.
Especially because a lot of babies are getting discharged at 24 hours.
Exactly.
I mean, that's, a vaginal delivery now, if they're there 48 hours, that's kind of the exception rather than the norm anymore. So a lot of this also falls on our outpatient providers, not just the stuff we catch inpatient, but when they go to that first peds visit in the day or two after being born or their first family practice visit. So a lot also too, we have to make sure that our outpatient providers are very keenly aware of this process because that's also where all that follow-up is happening. And yeah, you may draw the labs inpatient, but it's where they're going to have to be plugged into the system as an outpatient. So our pediatricians and our FPs are really going to have to be keenly aware of the outside the hospital process as well.
And that was a very early part of our conversation too, of whether or not it would be possible to do a routine measurement at 24 hours. And we got no.
Yeah.
Got a lot of no's because of that problem. But you're right, if we could, something like that, or if there's a routine measurement collected at the 2-day visit or 2-week visit, there's a few pieces where we might catch these babies.
Yeah.
We'll talk.
Thank you.
So on the CDC Zika website, they do have a page, a PDF document on how to measure the occipital frontal circumference. When we were developing that tool, there was different, do we we didn't want to overprescribe, say, do 3 measurements and use the middle one, or various methodologies that are out there, so it was kind of left. And one other thing that I'm not sure what the final document shows is, while I was on the working group, it was still in its infancy, but the user guide for the Zika Pregnancy Registry was perhaps going to include something on this, that if there's different measurements, it's difficult because it's going to be medical record abstraction for the Zika depending on the background of who's abstracting, how to interpret it could be difficult, but to consider if there are different measurements within the initial hospitalization or at newborn follow-up at the pediatricians, because as part of the U.S. Zika Pregnancy Registry, doing medical record abstraction of not only the newborn notes but also the outpatient follow-up visits, they should have head circumference on there. And then, I'm not sure if they eventually made a rule like at 48 hours take the maximum, or there was different rules that are talked, but it is being discussed and included in the, possibly will be included in the user guide for the pregnancy registry.
So one other question that was submitted during the break was, we've talked about this a little bit, but I want to give an opportunity for some others to share. So if we aren't currently testing the asymptomatic individuals, how will we compile research data for trends? I touched on it a little bit, the fact that we're looking at these different periods and these different processes, and now that we have sexual transmission, and now that we have a broader recommendation for testing pregnant women, babies with possible adverse outcomes, be it an infection, fever, or an actual defect. We're looking at testing moms and babies, but I'd love to hear some input. I'd love to allow some of our panelists to share some thoughts on that, on where maybe we're going with testing, or what some of the CDC discussion is around that.
Hi. One comment that I have regarding to the question is that at least for the pregnant women, which are the high risk group, and it's the group that has the the most severe outcome for the babies, microcephaly and potentially other outcomes. The Zika Pregnancy Registry is including all the women, symptomatic or asymptomatic, that have a positive Zika test result. So in that respect, CDC is using a wider case definition to include all the possible women who might have Zika or who might have a similar related flavivirus, and all the data that they will collect will be analyzed and used to inform public health and improve prevention for other women. So I think if on a wider scale we are currently not testing normal women or men that are symptomatic and don't have travel, though for the high risk group, we are following them. We will be collecting information for those that are positive. So I think that in that respect we will have better data for really the group that we mostly care about. I don't know if this is answering your question.
Yeah.
As far as what's on the horizon, there were no discussions that I know of changing laboratory algorithms to include all asymptomatic people. One of the largest reasons for that, as has been discussed, the difficulty in interpreting lab test results for asymptomatic individuals. We're just using serology tests, which we just don't have great, highly specific tests to test them. So if you think about what are your pretest probability, what are the chances of all these asymptomatic individuals having Zika, testing all of them, saying you have the funding and laboratory capacity for that, and then coming up with a reasonable interpretation of all of them, putting all those together, I think we're very far away from that being a viable, even for research in the near future.
So we have just a couple of minutes left. If anybody has questions, please, again, feel free to move forward. But in the absence of any questions, I'm going to ask my colleagues if any of you have any last take-home messages, last comments for this. We've covered a huge variety of topics throughout the day, and I'd love to hear any of your expert statements.
So we haven't heard much from people from clinicians from the hospitals or the outpatient setting, but I do want to convey that there will be a role for the hospitals and clinicians in helping us build the microcephaly surveillance system, and that is we will be outreaching to you, that is we, Diana and myself, We'll outreach to you to rapidly identify cases of microcephaly so that we can include them in the surveillance system. Our role at the ADHS will be to extract some information from the medical record on the cases that you bring to our attention. There's a benefit of the case registration in that it allows the local health department to follow up with the clinician on the child's development. This will be one of the measures that's expected of this public health surveillance system, and that is, how are these babies that have microcephaly, how are they doing? And then another benefit is that we will use this registration to assure that the babies that are born with microcephaly are getting connected into the services that they need to deal with their disability of microcephaly. So we will be we in the Birth Defects Registry will be partnering with the Office of Children with Special Healthcare Needs, the Arizona Early Identification Program, specialty organizations out there, and other specialty organizations that are out there that provide direct services and help to the families. So again, we're building this registry to make it a benefit for the families and the babies that have the condition.
Thank you. Anybody else? All right.
So one kind of closing comment for myself is that, there's a lot of talk about, so action needs to be taken for prevention, but it's not that we have no data whatsoever about what might happen in the U.S. with incoming flaviviruses or arboviruses, as we have had experience, some that was talked about during lunchtime, but not only in Arizona, but throughout the continental United States with chikungunya and dengue. And chikungunya only had a handful of cases in Florida, and dengue has had local transmission in Texas and Florida and other areas, but it wasn't sustained, and public health was able to control it. So trying to just balancing the message of we need to do prevention measures, but as particularly with our pregnant patients, that they don't have to, it's not the apocalypse is coming, that there's a balance to the message there.
Thank you.